Hi, everyone. Thanks for joining us today. I'm going to just give another minute or two for participants to hop on, and then we'll get started. Hey, I'm going to get started with introductions, and I see a couple more people have joined, so hopefully some more will hop on as well as we're talking here. Thank you again for joining us today. I'm Julianne Henstenberg, and I'm director of the MANNA Institute at MANNA in Philadelphia. We are a medically tailored meal provider who serves the greater Philadelphia, southeastern PA, actually community, where we provide medically tailored meals to people with serious illness and nutritional risk. Today, the Institute is the research and evaluation arm of MANNA. So we're currently looking at our outcomes and impacts of our medically tailored meal program. We offer 2 academic seminars a year. So this is our fall one today. And the title is Malnutrition and Care Transition in Older Adults, Implications for Practice, Research, and Policy. And we're so happy to have Dr. DiMaria-Ghalili today to join us. And I'll now tell you what we're going to cover today. There we go. So first of all, we'll give you just a little introduction to the MANNA Institute, and that will be followed by our seminar presentation and then questions and answers. Please put your questions and answers in the chat, and I will moderate those questions and answers at the end of Dr. DiMaria-Ghalili's presentation. We would also like to have discussion. So if you are doing interesting work in terms of transition of care in regard to people who have been diagnosed with malnutrition in your healthcare setting or facility, we would like to hear about that. So please also feel free to put any comments or discussion in the chat as well throughout the presentation. The MANNA Institute, our mission is to explore the impact of nutrition on health and people, for people with serious illness. And again, here at MANNA, we lead research and evaluation initiatives, both internally and externally. We also have a number of different kinds of programs and experiences for healthcare practitioners. So anybody who's interested in joining us for any of our research and evaluation efforts or training, please contact us, as we do have opportunities for various types of health professionals. We also work to share our findings and best practices, and our goal is to improve service delivery and healthcare transformation with the inclusion of nutrition and nutrition support and meals when indicated for people in healthcare settings. I'd like to mention that we are an ambassador for ASPEN, the American Society for Parenteral and Enteral Nutrition, Malnutrition Awareness Week. That did occur in September, but this program is attached to that week, and as an extension of that, we encourage you to go to the ASPEN website and look under all the resources they have for malnutrition work, if you could use those in your practice setting. So today I want to welcome Roseanne DiMaria-Ghalili. She is Professor of Nursing and Senior Associate Dean for Research at Drexel University here in Philadelphia. She also has courtesy appointments in the Nutrition Science Department and School of Biomedical Engineering at Drexel. She's a geriatric nurse scientist, and her continuously funded interdisciplinary program of research focuses on integrating nutrition and novel technologies to improve health outcomes and quality of life for older adults with acute and chronic conditions across the care continuum. So today we're going to hear about her work in malnutrition, and we're thankful to have her with us today. So I'm going to turn it over to you, Dr. DiMaria-Ghalili, and we look forward to your presentation.
Julie, was that on your end?
Yes, can you share your screen now?
Will do. 1 second.
Thank you.
Okay. I wasn't sure if it was on. Anyway. Okay, well, welcome everybody. And thank you, Julie, and for that terrific presentation, introduction. I'm just a little frazzled right now. And welcome everybody online. While my slides are up, I won't be able to see this chat, but look forward to some rich conversation and questions afterwards. And my presentation today will be on malnutrition and care transitions in older adults, implications for practice, research, and policy. And at any time during the presentation, if there's something that sparks your interest or your brings to mind something that you're doing in your practice, please put it in the chat and let us know so we can highlight some of the discussion points later on at the end of this presentation. And so my research has been focused on aging and looking at malnutrition in older adults across the care continuum. And what I'd like to start out with is just by refocusing everybody on why focusing on malnutrition in older adults is very important at this point in time. And, you know, we are really at an important time in this country. We are an aging nation. And more importantly, for the first time in U.S. history, there will be more older adults than children by the year 2035. And even though I have a role in academia, this is something that we're really very much concerned about. We call it the demographic cliff. 2035 is the year that we're going to have, again, more older adults than children. And so because of that, it's really an important time for us to prepare as healthcare professionals and community service providers to make sure that we are able to provide services for older adults. Importantly, you know, we're moving from this pyramid to a pillar when we think about our demography in this country. When we think back to 1960, we were a pyramid. There were much more younger adults, and it was really just a few people who got to live to 85 years of age and older. But when we fast forward to 100 years from 1960 to 2060, we're really going to see a pillar. And not only are we going to see more people 65 and older, more baby boomers, but people are going to live well past 85. And so because of that, we need to really be prepared to address this in healthcare. Now, as people age, we know that there are a lot of risk factors for malnutrition in older adults. And, some of these are physiological risk factors. Some are the co-occurring chronic conditions that happen as we age, medications, psychosocial factors that can impact one's nutritional status, like loneliness, depression, economic risk factors, such as living on a limited income, as well as environmental risk factors and many other social determinants of health. So it's really important that we begin to think about screening older adults for malnutrition across the care continuum so that we could identify them early and implement appropriate interventions. And why is this important? Why do we particularly care about preventing malnutrition in older adults? And I think this is a slide that I've rebuilt from Sharkey's work back in 2008. And it's really so important because it shows this continuum here. Poor nutritional status in older adults, there's risk factors, as we mentioned, for poor nutrition, which can lead to inadequate protein and energy or micronutrient intake. This poor nutritional status could trigger functional decline at weight loss. If we know people aren't taking in enough calories and protein, they're going to begin to lose muscle mass. And in older adults, that's very detrimental because we will see decrease in strength, decreased power, walking speed. So these are all precursors to frailty. And again, we will begin to see negative health outcomes, poor recovery, disability, and eventually frailty. So it's really important that we start early and look at enhancing appropriate nutritional intake so that we could prevent this disability decline. And more importantly, as a nurse, I spent a lot of time working in the acute care setting. This is the continuum of care. And we spend a lot of time talking about malnutrition in the hospitalized setting. But this is really a good time today at this seminar to talk about the continuum of care, because all of us who are providing services to individuals need to really think about how can we reach out and ensure that they're receiving appropriate nutritional care. This is whether they're in the home, wellness and fitness centers, those that are working in physician outpatient offices, and, of course, the hospital, but then it goes out to extended care facilities, skilled nursing facilities, and in the home setting. So it's really important that we provide nutrition screening across all of these settings. And what becomes even more complicated is that there is really this spectrum of senior living options, right? And a lot of these settings are not as regulated as they are in the hospital setting. So we have adult daycare centers. There could be retirement communities, continuing care retirement communities, assisted living, personal home care, dementia care units. So all of this is very different in the terms of level of care and supervision that individuals receive as they're living in these alternative settings, and as well as the nutritional services that are provided in these different settings. Now let's take a pause for a moment and think about what do we know about malnutrition in the hospitalized setting? Well, ASPEN, the American Society for Parenteral and Enteral Nutrition, spends a lot of time looking at this. And one paper, I was lucky to be on this publication team that was from 2014. We looked at healthcare cost and utilization data, or HCUP data, from inpatient hospital stays. So we were able to look at that data from 2010 inpatient hospital stays, and there were 39 million hospital discharges that we analyzed, and 1.2 million, or 3.2% of that sample, had a clinical diagnosis of malnutrition. So this is what was coded in the medical record. The mean age of those with malnutrition was 64.8 years of age, so older adults. And older adults accounted for 58% of all malnutrition diagnoses. And as you can see here, the distribution was there were 42% were 65 to 84, and 16% were 85 and older. Fast forward another 8 years, Peggy Gunter and the team at Aspen repeated this data, looking at 2018 discharge data from the Healthcare Cost and Utilization Project. And again, now we had about 8.9 million individuals with the clinical diagnosis of malnutrition. But what was not surprising is that the mean age of those with malnutrition continued to be older adults, and the distribution between young and older were about the same as from the 2010 publication. So what are some of the facts? We know that people who have malnutrition in the hospital setting tend to be 65 years of age and older, have higher rates of infection, longer lengths of stay, higher costs, higher rates of death, and higher usage of home care. So that was from some of that original data that we found. We also did a deeper dive on this data, and we found that older adults with a malnutrition diagnosis were more likely to be admitted to the hospital from a skilled nursing facility and more likely to be discharged back to a skilled nursing facility. We also know that weight loss increases the risk of 30-day readmission in medical patients, and that failure to thrive or malnutrition is a frequent reason for readmission in surgical patients. So we know that we need to do a better job at preventing or addressing malnutrition during these handoffs in the care continuum. Now, one thing that we don't have in the United States is really a robust metric to assess malnutrition in community dwelling older adults. Okay, so what we did was look at the National Health and Aging Trend Study. This is a longitudinal epidemiological study that's run out of Hopkins, and the data is available for public use. And we looked at their data from 2017, and we were able to, based on the questions that were in the data set, ask or assign a mini nutritional assessment score. And what is really interesting about this sample is that it is a weighted sample of community dwelling older adults in the United States. So this gives us a very good picture of nutrition risk in those living in the community. And again, this is the age distribution of the sample. We broke individuals down into 65 to 74, 75 to 84, and 85 and above. And what we found here was that there was a great incidence of malnutrition or at risk for malnutrition in those older adults, especially those 75 to 84 and 85 and above. So again, this points to the fact that there is malnutrition in those who are living in the community. Now, this is those of you who have heard me speak before on transitions of care. This is a story that I bring up a lot of times, and I think this is where places like MANNA and organizations that provide home-delivered meals really come into play. This is a story from, about 8 years ago, a true story in Fayetteville, North Carolina, and it hit all the different media outlets at the time. This is a gentleman who was discharged from the hospital after being in the hospital for cancer and then being in a rehab center. He went home and he lived home to an empty house. He lived alone. And you know what happens when people are discharged. The day of discharge, home care services don't start immediately. It usually takes about 24 to 48 hours before home care comes out. The nurses come out, do an assessment on individuals. And so this gentleman went home and had nothing in the house. And so he called 911 because he was hungry and he had no food. And the whole, of course, the media just jumped all over this story because all of the 911 operators and dispatchers responded and brought him meals and food. And it was a really feel-good story. But as much as it's a feel-good story, it really highlights what older adults experience when they're going home from the hospital and how can we bridge that gap. And it's really important for us to really think about how prevalent is malnutrition across the care continuum and what are the barriers and facilitators for best treatment options during those care transitions. We spend a great deal of time emphasizing malnutrition risk in the acute care setting, but my pitch is always, well, people go home after that, and how are we getting them the services that they need? Older adults are living longer. They may need different levels of care and supervision over their lifetime, and we really need to think about how are we going to reach out and provide the best nutritional care during these transitions. We know that malnutrition rates are usually documented based on their admission rate. When people are admitted to the hospital, there's a lot of screening that's done, but we don't screen people when they're discharged from the hospital for their risk of malnutrition. And it's not really mandated in home care that we report rates of malnutrition. So this is really a big gap that we have, and we need to continue to address that. We did a study where we looked at nutrition screening at hospital discharge. We actually looked at nurses' nutritional care practices in the United States. It's a small, convenient sample, but we asked these nurses, well, do you go on and screen at hospital discharge? So we had a small sample of 174 nurses that worked in either hospital or long-term acute care settings, and the majority reported doing a nutrition screen on admission, and only 38% reported reevaluating nutrition at discharge. So again, this leads us to, emphasize that we need to continue moving toward rescreening individuals when they're getting ready to leave a hospital. This was a study by Brooks et al. In 2019, where they looked at hospital discharge nutrition care instructions in those patients that were diagnosed with malnutrition. So what they did was they reviewed the electronic medical record, and for those who were diagnosed with malnutrition, and they looked to see what was provided or what was prescribed in terms of discharge nutrition care instructions over a 4-month period. And interestingly, only 6% of those who were malnourished received discharge instructions to consume an oral supplement after discharge. 47% of those who were malnourished received general diet instructions from the providers that did not address malnutrition. And actually, 45% received inappropriate instructions to limit caloric intake, even though they were already diagnosed with malnutrition. And so, the problem we know with a lot of these pre-canned EMR, electronic medical record, discharge instructions is that they need to really be tailored, and clinicians will often just check off different kinds of patient education without really thinking about tailoring it to some of these diagnoses. This again is another study that was done in 2015 from the Gerontological Society of America and the National Academy on Aging. Whoops. So they commissioned a study to look at older adult malnutrition in individuals who were either self-identified as adults or non-paid family caregivers of older adults. And this was done through a Harris panel. So there were some interesting findings here. So first they asked older adults who were in the hospital what their transition perspectives were, how long they were in the hospital, did they have an inpatient hospital stay in the last 12 months? And if they responded yes, they were asked, were you asked any questions about your appetite, diet, weight, or nutrition on admission or other times during the hospital stay? And 65% of those older adults said yes, they were asked those questions. Only 33 said they received information about appetite, diet, weight, or nutrition at discharge. Only 17% said they were referred to a dietitian or nutritionist upon discharge. Only 15% were referred or enrolled to a home meal delivery program upon discharge. And only 12% said they received meals at a community center or a senior center upon discharge. Only 24% said they were referred or enrolled in SNAP upon discharge, and only 18% said they received an oral supplement upon discharge. And 33% said they received educational materials on diet and nutrition upon discharge. And then they asked individuals who were caregivers about their transitional care perspectives. And they asked the family members, your loved one who was in the hospital, were they asked any questions about their appetite, etc.? And you can see here are the responses. Were they referred to a dietitian or a nutritionist upon discharge? And only 17% said yes. More importantly, they asked the caregivers what specific nutrition actions would have been most helpful for you and the older adults in your care. And the top three responses were: 1, to receive educational resources; 2, to receive coverage for reimbursement of oral supplements; 3 was to receive referrals to community nutrition resources. Then they asked the caregivers, which community nutrition resources does the older adult you care for currently use? So 56% said they did not receive any community resources. And then the remainder who said they did receive resources, 21% said they received home delivered meals, 20% said they received meals at a community or senior center, 19% received a SNAP, 16% received food assistance programs like food banks, food pantries, etc. And 15% said they received local transportation services to and from nutrition programs. Which community nutrition resources would you like older adults to use? 30% said home delivered meals, 23% said meals at a senior center. So you can see how important providing meals for individuals when they're discharged from the hospital is. So what are some of the key takeaway points from the study? The strength of this study was that it was a weighted, represented nationwide sample. It provided a unique end user, I don't know why my screen keeps jumping, unique end user perspective. And a weakness, though, of this is that we don't really know what percentage of older adults were malnourished. So I want to just highlight some global perspectives, because what we're talking about is just not unique to the United States or to Philadelphia. There was a survey that was done in 2018 in Scandinavia, where they looked at survey of nutrition routines at discharge by physicians and nurses. And what they said was they reported that less than 25% of individuals had a weight recorded at discharge. Less than 20% had an evaluation of nutritional status at discharge. And less than 63% reported that nutritional regimens that were started in the hospital were included in discharge summaries. And very similar trends in Norway, looking at patient and family caregivers' perspectives. This group did a qualitative study with 15 older adults who were documented to have malnutrition or at risk for malnutrition. And some of the themes that came from these qualitative interviews were that there needs to be a comprehensive approach to nutritional care from the hospital to the home, that there needs to be individualized nutritional care in the home. And this many older adults and family caregivers viewed as being problematic, that meals, if they received meals in the home, they were not tailored to likes, and that there needs to be an important role for family caregivers, need to be included in the discharge plan. Again, Israel, a study done in Israel looked at adherence to dietary regimens post-discharge. And again, this specifically looked at older adults who were treated with an oral supplement in the hospital. And what they found was that there was a lot of barriers in the discharge to adhering to oral supplements. Again, in Belgium and Denmark, a lot of transitional care barriers focused on education, individual knowledge and attitude, lack of training and experts, lack of communication from the hospital to the home setting are reasons for nutritional therapy. And a lot of times therapy is not started at discharge. Heather Keller and her team in Canada are doing some amazing work in terms of nutrition care pathways. And this was based on a publication in Journal Parenteral and Enteral Nutrition in 2022, and they identified consensus-based nutrition care pathways from hospital to community for older adults in primary and community care. And again, they really did a great job highlighting some of the barriers and facilitators to primary care and community nutrition care practices. And these include nutrition care plans at hospital discharge, nutrition risk screening, weight monitoring, appetite monitoring, dietitian referrals, educational resources, and community services. So these were all areas that we could really address. So moving forward, so what are some of the interventions that we really need to focus on? Well, education, of course, we need to focus on highlighting nutrition education across healthcare professionals and community service providers as well. We know lots of ways to increase intake in those who are malnourished, whether they need specialized nutritional support like total parenteral nutrition or tube feeding, therapeutic diet, oral nutritional supplements, home delivered meals, or congregate meal services. And then we need to really think about what are some of those social services that individuals need, like homemaker support to help them with feeding, shopping, and cooking, transportation services, and SNAP. And this, is a snippet from a presentation that I gave several years ago at the National Academies of Science, Engineering and Medicine, where we focused on meeting the dietary needs of older adults, exploring the impact of physical, social, and cultural environment. And I really think we need to rethink the models of care in terms of nutrition. And of course, it would be terrific if every individual received an assessment by a dietitian. But we know that in the home setting and out in the community, well, first of all, we know that there's a healthcare professional shortage, number one. And we know that there's even less dietitians that are out there in the community settings. And so we really need to think about providing what are the interventions, low risk interventions that could be delivered by social workers or community health providers in terms of those that need nutritional care. What are the medium risk interventions that could be delivered by nurses? And, those who are really high risk, who are severely malnourished or have malnutrition, what are the interventions that need to be delivered by the dietitian? So I think we need a tiered approach that we could all work together to meet the goals of individuals, especially older adults, as they transition from the hospital to home. So in summary, I think we need to have a peer approach, that we need policy changes. We need to advocate for practice changes. We need to advocate for malnutrition screening at discharge and upon admission to home care. We need interventions. We need to implement the appropriate interventions across care transitions and recognize the importance of continued monitoring. And that's key. We can't just intervene without continued monitoring. And I think now is an important time for us because there is a bigger initiative and a lot of push today about food as medicine opportunities. So I think now is a good time to really think about how can we reposition some of these interventions in the community setting along the lines of food as medicine. And I think we have to continually educate our healthcare professionals about the importance of nutrition screening during care transitions. And we need to continue to do research in this area to promote positive outcomes and improve recovery in older adults. And, together we may think that nutrition during care transitions is impossible, but if we work together, we can make this possible. So with that, I will pause and thank you for your time, and happy to take questions.
Thank you so much, Roseanne. And I'm please, everybody, put some questions in the chat. If you are, it struck me this difficulty we have with transitions, which has really been in place since I worked in hospital, which is a while ago. almost 25 years now, we were having the same issues. If you are doing work out there that is, you have a program of transitions and nurses and dietitians and social workers are involved in a team-based approach or any approach really, put it in the chat and let us know about it. We'd like to hear what you're doing. So please put any more questions in the chat and I will read them to Roseanne. I have a question to start out
Sure.
with. And again, just having had the same experience 25 years ago where this was really, really also difficult. When you really like hone in on what's happening in, let's say, hospitals and healthcare settings right now, what do you think is the biggest barrier to making this happen? Is it money? Is it staffing? Is it time? Is it is there something that could be changed or that is shown to work in US healthcare systems that in
Yeah.
general, that might make a difference in having better transition? Because we're going to be, as you pointed out at the beginning of your talk, we're going to be having so many more people who are older adults at risk of malnutrition. And I think like just living sort of independently, but dealing with probably chronic disease processes.
Exactly.
So is
Yeah.
there something that if put into place that was more on a universal level could work better at this point in time?
So I think that's a great question. And I think there's a lot of examples out there. There are some health systems that will, depending on people's age and their chronic conditions, will send individuals home with meals, with like 2 week supply of frozen meals. And there's pros and cons. I don't want to get into all the different types of
Yeah.
food that's out there and how it's delivered and whatever. But if you think about it, that's really critical because look at the example in the picture, in the presentation of that gentleman that was discharged from the hospital. Even if you're malnourished or not, if you live alone, you're
Yeah.
so debilitated and weak from being in the hospital for a few days. If you're an older adult, you're not going to have the energy to prepare food and go out and do the shopping, right? Unless you have someone that can do that for you. So I think it's really important. A lot of health systems are starting to think about that. We need to see more programs like that out there. So I don't know. That's one. Number two is I think there needs to be a concerted approach. I've heard, people will say that there's usually a long waiting list to get into Meals on Wheels programs or community based programs. So I think health systems really need to work very closely with their community partners to help make sure that individuals get the services they need when they're just, a warm handoff instead of just sending people home with visiting nurse or whatever, and then waiting for the home care nurse to come in and hook them up with community support. That I think they need to go home with that at the time they leave the hospital.
Yeah. And I think, oh, what's that?
Challenging though, right?
Yes.
We all know.
Yes. There's something I think this is in the policy realm that Pennsylvania is working on right now. You might be more aware of it than I am, as a sort of universal tool to help people connect to resources in communities from healthcare. So that's about as much as I know. If anybody on the call knows a little bit more about it. And so one of our questions in here is how can we go about working on getting more coverage for nutrition care from dietitians for clients? Another just long-standing age-old question. So I know one of the things you presented, and I'd be interested to hear if anybody's working on this, because I know there are a lot of dietitians on the call. But I think one of the things you presented is sort of level of care that we should come in when it's like really more complex, and that is to our level of training, a lot of and as well nursing as well,
Right.
and then a lower level that for people who don't get the kind of nutrition or physiology courses that we get. Social workers or case managers at the bottom tier. And I do you know anybody who's doing like any train the trainer programs on like getting more people like truly able to handle some of the baseline things that happen.
Yeah, I personally don't know. I think there are a few studies that are ongoing that are out there that people are implementing some of the screening into like home delivered meal programs. So I think
Mhm.
we need to see some of those
Right.
results come back. I think we need to think smart about training. And COVID's changed things a lot too, right? But
Yeah.
also, our drivers that are delivering meals, right, to individuals, how could they be trained to do assessments on the environment or what the individual needs? There's a lot that we could implement, just
Yeah.
screening questions, right, along the way. I also think there is a need to think about for older adults, the annual Medicare screen to make sure that family doctors, primary care providers are doing a better job with screening, and referring out. So that's the whole thing. We could screen all we want. We know that. But if someone is diagnosed or is screens positive, you need to refer them out to the dietitian and make
Mhm.
sure they get the services that they need. I think we all have stories in our own families of where there were missed opportunities with older adults that we care for.
Yeah, absolutely. Um, and the second half of that question, dietitian care is not covered by insurance. It's extremely limited, especially with Medicare. Yes, that has been a longstanding issue as
Yes.
well. And for the dietitians on the call, I encourage you to look at the Academy's website in the policy realm for the medical nutrition therapy bill, which has been introduced in the last few Congresses, and it's getting ready to be reintroduced this Congress again. And that is a bill that expands the diagnoses available for MNT under Medicare. So right now, as you all know, we just have renal and diabetes, and so that will expand them to our normal set of 15 diagnoses or so, our normal set of things that we would have under medical nutrition therapy that we would get paid through Medicare, and then that usually falls down to other insurances at the state level. So watch for that. Go to the Academy's website in the policy realm and watch for that to be introduced, and then write to your Congress people to support it. Should be both in the House and the Senate, bill separate, two sister bills.
That's
Um,
great.
so one of the things you just mentioned also, and I'm getting to the idea of this other question here. How do we ensure those who screen positive at discharge receive appropriate care after discharge? And so one of the things I'm thinking of is, and I was just wondering if you have any experience with this. So we've always talked about, you just talked about screening in primary care. And, that's kind of the community-based
Hmm.
care model that we've always used, regardless of where you get your care. I just wonder, is there any movement to people getting more care? Because I love your care continuum slide. But one of the bigger things is it's just a perception of mine, but it's happening is more referrals to things like urgent care when primary care is closed. It's almost like we're moving from that ER model to, go to urgent care now. And also pharmacies, because they're really getting into the business of healthcare in the minute clinics or other kinds of things like that. So can you see a model where there'd be more of any of us in those settings, or do you know if that's happening anywhere where we have more access that is maybe in non-traditional settings to
Yeah,
dietitians or other care people?
I'd love to know what people on the call, have seen. But every time I go into this, I have a CVS that I go into that's a hub, and they have more. There's a dentist in there, but I've never seen a dietitian yet. And
Yeah,
that is challenging. I do know I've seen in the literature examples of some supermarkets that will have dietitians, in supermarkets at certain times to help people shop and make appropriate healthy choices. So I know, but that's probably more of a corporate decision, right, than necessarily a healthcare decision. And I think you're absolutely right. There's such a missed opportunity. I think we need to retool and think about urgent care centers because there are more and more of them around. And think about how can we get educational material into these
Yeah.
centers for sure.
Yeah, and we haven't really thought of them in terms of resources for the community, having access to,
Mhm.
better resources there. Because I think they're doing more primary care in some
Yeah,
ways, right? And
yeah,
they're
mhm,
selling it in some
mhm.
way.
Yeah, I agree.
So that might be also a way to get better care for people who are struggling with malnutrition in
Mhm.
communities, a little separate from traditional. Um, any other questions today? Does anybody else have any thoughts or want to share anything that you're working on or doing? Um, uh, let's have one new message here. Okay. Um, so here's a question. Who has the ability to prescribe oral nutrition supplements once a patient leaves the hospital? This is a nutrition student. Has had a couple of clinical rotations. I've been not been able to provide prescriptions for oral nutrition supplements. However, there's some other hospitals, dietitians can do that. I, I can speak to that a little bit too, but and tell you a little bit about the prescription or the diet prescription piece by dietitians. But says oral nutrition subs are so expensive, so I'm really curious how that could be feasible for patients once they leave, right? And I've also seen this, like pharmacies will give a pack, right? Upon
Mhm.
discharge, here's your oral supplements, and this is what you need, and go get them. But you're right, just then it trails off. They're not covered by insurance usually.
Yeah, and I think so. I I think oral nutritional ONSs are a really important part of the intervention, but I always think there's an important educational piece that goes along with that because we all know, Julianne, right, that oral
Yeah.
supplements were started to supplement someone's diet to give them
Right.
extra calories and protein. And a lot of times it just turns out to be a meal replacement. And they're not getting enough calories and protein. So I think that's the educational piece about how do you add more protein into somebody's diet, more calories, even with if you could give them soup and they eat, there's different tricks of the trade, right? To get
Mm-hmm.
protein and calories in without even giving it an ONS when people are in the home setting. So I think, ONS oral supplements are important and they play a really critical role, but they shouldn't be used as meal replacements. And I think that's the biggest point that we want to take back. And honestly, you could go into Walmart, you could go anywhere, and they have aisles of that you could get oral supplements. You could get generic brands, you could get the trade brands. So it is costly. I will say that we know that, and that's why having it, if it was covered with some prescription, depending on I think some clinical conditions, you can get it covered, but um, it all depends on insurance and
Yep.
depends.
Yes. And actually, if how can you say, on the outpatient realm or in the community, the dietitians can make any recommendation they want. If they, in fact, are assessing a patient and feel that they need oral nutrition supplements, they can say that and provide the patient with the resources that they can get them because they're available to buy over the counter.
Right.
Um, in hospital settings, diet prescriptions have a regulatory component to them. Dietitians are allowed under Medicare regulations to do diet orders, but you have to follow the rules of your medical staff. So your medical staff has to agree that that can happen in your facility, and then you have to go up the ladder in your state and get it approved in whatever regulations you need to that oversee hospitals. In fact, up into Pennsylvania, it's up to the Department of Health and Human Services to get approval to do that after your medical facility allows you to do it. So it can be done, but it has to be approved facility to facility. And right now, because it's under Medicare regulations. So if you'd like to know more about that, you can contact the Pennsylvania Academy of Nutrition and Dietetics, and they'll help you with that. Do we have any more questions? I'm going to just go back to the beginning here. I'm sorry, I missed this one. I love the idea of a rescreen for malnutrition risk at discharge. How would you recommend organizations go about implementing this practice?
I think it's a health system perspective. I don't even say hospitals anymore because I don't think there's any like standalone hospitals.
Yeah.
Health systems really need to espouse it, adapt it, and realize that, people who leave the hospital with malnutrition are more likely to come back and be readmitted. So it's a decision. It's about providing better care and improving people's quality of life. So I think it's really health systems have to figure out how to do that.
Yeah.
And then it's just not rescreening, but it's getting the intervention. And I think that's the tricky part, right?
Right. Yeah, because the person said, do you think the addition of the discharge screen will result in more appropriate interventions? It's almost like another nutrition assessment. As you're going back into your home, you may have different needs, right?
Correct.
In addition to addressing the malnutrition. So
yeah.
Let's see, I have another question here. In the outpatient setting, oral supplements need a physician order and a qualifying diagnosis. May or not be covered based on insurance, can be prescribed by a PCP, primary care professional or specialist. Okay, like if you wanted somebody to drink Ensure, would that need a physician order? I guess I wasn't aware, but
yeah, I don't know what is meant in the outpatient setting, if it's like a clinic that's affiliated with a institution, but a caregiver can go, a friend, a neighbor, you could just go into any Walmart supermarket and purchase oral nutritional supplements yourself. You don't need it's over the counter.
yeah.
So it's your decision. I think it's the reimbursement model. It's not paid for.
Yes, right. Yeah, and in some patients who may have mild malnutrition and things like Carnation instant breakfast can suffice often,
Sure.
which is a cheaper alternative to that. But again, it's doing a good assessment for all of us, our nursing assessment, our nutrition assessment, and really trying to put in place what people need at any given time. And I'm sure that changes in the community, right? Yeah.
Yeah. Thanks, Kathleen. Yes, if it's to be covered by insurance and have sent from
yes. Okay.
company. Yeah.
Great. Thank you for that. Anybody else have a question? We have just a few more minutes. Just give it a second. This has been just such a great discussion today. I've learned so much. Thank you. Anybody else have a last question for us? Otherwise, we'll give you back a few more minutes of your day onto your next meeting, right?
I know.
Okay, well, I'm not seeing anything come in. I want to just thank you so much again for sharing your knowledge and experience with us today. This has been a fabulous presentation and discussion, and we very much appreciate it. So thank you, Roseanne. Thank you, everybody on the call. And we appreciate your being here. So have a great day.
Have a great day.
Bye-bye.